All right, Unit 11 and 12, Emergency Care and Bioterrorism. So what is the definition of emergency nursing? It is the assessment, diagnosis, and treatment of perceived, actual, or potential sudden or urgent physical or psychosocial problems that are primarily episodic or acute. So the scope and practice of emergency nursing focused on urgent and critical care needs. So they are treat 'em and eat 'em is what they say in the emergency room. Emergency nurses need special training, education, experience, and expertise in assessing and identifying healthcare problems in crisis situations. They are there not to fully treat the patient. They are there to stabilize them long enough to get them up to the unit to keep them alive. So nursing interventions are accomplished interdependently under the direction of a physician or nurse practitioner. The emergency room staff work is an interdisciplinary team that includes your pre-hospital care providers, so like your EMTs, your paramedics, or even your 911, your police officers, and then you get to the paramedics, the EMT. From there, they come in. Normally, if they're on the truck, they're going to be calling into the ER saying, hey, we're on our way with this patient. There's a little bit of background to prepare the emergency room staff. Physicians should be there at all times, 24 hours a day, support staff, and an inpatient unit staff. When your patient comes in, we need to make sure that we have good identification of that patient. We need to make sure that we're preventing further injury to our clients. So making sure if we have one massive diagnosis that we're looking at the complete body so that we understand that, hey, this little thing that is like in the background could potentially cause some major problems for that patient. Risk for errors and adverse events, they do happen quite more often in the emergency room because they're working so quickly to get that patient stabilized. And ultimately, we want to prevent injury to staff at all times. Cultural awareness is very important. I cannot tell you how many times as the charge psych nurse at St. Anthony's, how many times I went into a patient's room because the nurse said they were getting violent with them or throwing stuff at them, when it is they did not approach the patient kindly. Maybe they have Indian descent or ethnicity, Middle Eastern, where maybe it's a woman in there and they're not supposed to have a male nurse or a male physician. So just being culturally aware. This also is important because we have to customize our education and our discharge instructions to fit that client's need. Take your Jehovah's Witness. Can they have blood products? No. Take your Jewish population. Make sure everything's kosher. Consider client's reading level, primary language, and visual acuity. Education materials instructions, at least at a 6th grade level or at maximum. So not all of your, especially your elderly patients, not all of them can read. Materials available in Spanish or other languages. Most of the hospitals, they have that standard like discharge instruction that can be printed out on the certain disease process, but if you go into their library, they can have that in multiple languages. And then this lovely phone, I have not seen this lovely phone in forever. It used to be our language interpreter. Now we use things like iPads and phones, but the nurse was on one of the phone lines and the patient was on the other, and then you called into the number and it connected you to the interpreter. So triaging your patients, sorting clients by hierarchy based on the severity of their health problems and the immediacy with which these problems must be treated. Our lay people, our people coming into the emergency room, most of the time do not get this component. And sometimes our ER staff are so short staffed that they can even appropriately care for that level, that higher level of acuity, if there's multiple of them coming in. So triage nurse collects data and classifies the illness and or injuries into the triage categories. This is the first person you're going to see. Is it a broken toe? They're not on the priority list. Protocols may be initiated in the triage area. There's someone constantly out in, well, supposed to be out in the waiting room area, monitoring, just making sure no one's falling out on you. Clients who are the most critically ill receive the most resources regardless of potential outcome. There are lots of laws to protect the patient. If they are uninsured, if they don't speak a certain language, race, ethnicity, gender, it does not matter. If that patient comes into the ER, they have to be treated. And then triaging 6 months to 1 year experience. You kind of have to know what you're looking at. You have to be able to get that critical thinking going. Emergent, urgent, and non-urgent categories. So emergent means immediate threat to life. This is where you're going to see more cardiac. Are they complaining of chest pain? Are they becoming lethargic? Or is there altered mental status? Do they look like they're having a stroke? Is there respiratory distress? Are they modeling? Unstable vital signs, active bleeding. And then your urgent is those major injuries that require immediate treatment. So severe abdominal pain, renal colic. Do they have multiple fractures? Do they have a bone sticking out of their body? Tissue injuries, respiratory infections, especially pneumonia in your elderly patients, and new onset of abdominal pain. Now, if they're sitting in the emergency room and they came in with abdominal pain and all of a sudden they don't have any, that's going to push them up to emergent, because that could be like your 17-year-old with a ruptured appendicitis, and that means that they're going to go septic. Now, your non-urgent, minor injuries that do not require immediate treatment. This is the one where people get confused on, do they go to the urgent care, or do they go to the doctor, or do they go to the emergency room? So if they have a skin rash, they have a bee sting. Now, if they have a bee sting and they're going into anaphylaxis, definitely emergency room. But if they are not allergic to bees and they just have some minor swelling, urgent care. Or they can go in the emergency room, but they're going to be waiting there for hours. Simple fractures. Simple fractures are typically splint and wait. Do not move that extremity. So let's say you have like an 8-year-old that fell off a tree. They broke their arm. Depending on where it is, and if it is a simple fracture, meaning that they don't have any kind of part or bones floating around, that's not open, it's closed, you can literally see on the x-ray that it's a clean break. You're going to splint it, and ortho will follow up with them hopefully the next day. They're not going to see emergent orthopedic surgeon for that simple break. You're going to splint it as it lies and have them follow up with ortho the next day. So death in the emergency room. This happens quite a bit. If you start, I always lecture on this because I feel like working in the emergency room can create a lot of trauma. Even your paramedics, your EMTs, your firefighters, police officers. There is a component of post-traumatic stress with that. You're working hard all the time, your adrenaline's flowing, and ultimately your patient dies. You are going to have some issues. And being able to recognize that and have healthy coping mechanisms is very important. You're going to see a lot of sudden, unexpected deaths. Family could have this issue as well, especially if they are there while the whole crew is trying to resuscitate that patient. Special circumstances when medical exam or case involved. So this one is tricky because the rules have changed within the last decade. Prior, it used to be just all your suspicious deaths were going to get the call to the medical examiner. But if they had anything such as even a slight cold within the last 3 to 6 months, I believe, they get a call to the medical examiner. Hey, do you want to do an autopsy on this body or not? It does not matter. Is it a dog bite? Autopsy. Is it any kind of suspicious death? Autopsy. Do they have bruising or any kind of injury prior to the death? They're going to go to get an autopsy. So the medical examiner is the one that's either going to accept or reject it ultimately. Family can fight for getting an autopsy, but the medical examiner is pretty much going to say, yeah, I'm going to accept the case, and that's where the body's going to go, to the medical examiner. Of course, after the family has grieved. Now, reasons the medical examiner may not accept the case: if they're elderly and maybe they were on hospice, the death is kind of expected, but you still have to call the medical examiner. Trauma, death, homicide, any type of abuse, neglect, any type of trauma, you are not going to clean up that body. Why? Because there's stuff on that body that the people need to swab and gather to get evidence, especially for court. Dealing with family members in a crisis is very difficult. Hopefully you have a psych nurse in the emergency room that is there to kind of help, or even a social worker, case manager that's going to help de-escalate the situation, provide them with resources, be a comforting ear. If client dies before the family arrives, do not tell the family that the patient has passed away. Tell them that they need to come to the hospital, that their loved one is there, but they do need to come as soon as possible. Cover the client with a blanket. Be respectful of the deceased body. Leave the face exposed. Dim the lights before the family enters the room. So, mechanisms of injury: manner in which traumatic event occurred. That could be a blunt force trauma, a blast effect like a bomb, acceleration, deceleration force. So, like we talked about with our head injuries, you hit your head in the front in your car accident. Maybe you hit the airbag, or the airbag hits you, and then you hit the back of the seat. You got that acceleration, airbag hits you. Deceleration, you hit the back of the headrest. And then, of course, penetrating trauma, which we see in this lovely picture. The primary survey, and there's a primary survey and a secondary survey regarding resuscitation interventions. So primary survey organizes the order of approach to the client by mnemonic device: A, B, C, D, and E. Airway, cervical spine, breathing, circulation, disability, and exposure. So you're surveying the patients as they're coming in, and the higher the category, so like A is the highest category, B is second highest, and so on. If the scene of a motor vehicle crash, you must first survey the scene to make sure that you are safe. Because if you go on there and there's like electric line and then a big old puddle, you're not going to be able to do CPR on them. You're going to be laying right there with the other person, and that's not going to help anybody. So looking at our disabilities, so the D part, we know our ABCs. Disability is neurostatus assessment and reevaluation, frequently using your Glasgow Coma scale. Remember, the highest number is 15, and the number that we worry about is anything less than 8. So if 8 or less, prepare for mechanical ventilation. Exposure: remove clothing. So if they've been exposed to some kind of anthrax or something. Remove clothing for assessment purposes. Always cut away with scissors when rapid assess is critical. So, if manipulating limbs, you could cause some injury. Thermal or chemical burns, use fabric to melt. Don't use fabric or put fabric on there. It'll melt with the skin. Remember, with our chemical burns, we are brushing off the stuff. We're taking those clothes off, we're cutting it off, we're containing those items, those clothes. We're not putting them back through the washing machine. We are swiping the skin, brushing it off. We are not putting anything else on that skin because it could melt into the skin. And then prevent hyperthermia. So use heating devices depending on how severe hypothermia is. If you are starting to notice necrosis or any kind of severe tissue damage, that's past hypothermia. That's more of your frostbite, and we're not going to use heating devices for that. Use blankets and warm solutions. Galen provided some lovely, lovely pictures that I love how this lady in the background is looking like, oh my gosh, I don't know. So this is a woman who sustained a single gunshot injury. She survived at the hospital conscious and breathing spontaneous, impossible mask, ventilation, and difficult intubation, as you can see. Very difficult. And we see this is a closed fracture, but it looks like it's a clean one at least, but that definitely needs some help. Yikes. This is a car wreck into a guardrail. They cracked his chest beside in the ED, at bedside at the ED. This is in the UK. Lived for a week, but ultimately had a thromboembolism and died. Alright, so you did your primary survey. That is your airway, breathing, circulation, disability, environment. So our secondary survey is a comprehensive head-to-toe assessment. You know what's wrong with that patient. You did your primary assessment. So let's take your head injury patient. You know that the head is the problem, but let's say they also have that foot, that broken ankle. That's your second issue. So that could potentially cause a problem after the head well, it could cause a problem while the head is injured, but that's not your primary issue. Your primary issue is the head injury. That's primary survey. Secondary is all the other stuff that could be complications outside of that head injury. Identify other injuries, issues that must be managed or may impact the course of treatment is your secondary survey. Management of clients with abdominal injuries. So blunt or penetrating injuries, they're going to need surgery. Abdominal trauma can cause massive life-threatening blood loss to the abdominal cavity, and we're always going to assess. You in the emergency room, you see a lot of nurses doing focused assessments, and they'll tell you this is because we don't have enough time. We're treating them and getting them out as soon as possible. I'm going to tell you, as a new grad, you are not do not do that. Make sure that you are assessing the entire body, because you're going to miss something, and ultimately that's going to come back on you, not anybody else. So get a good history if you can. If you know it's an abdominal issue, you're also assessing everything else. Let's say they had a AAA. Well, assessing cardiac rhythm is going to be important. Don't just assess the abdomen. Perform abdominal assessment and assess other body symptoms for injuries that frequently accompany abdominal injuries. So anything in the trunk area is going to be problematic with any kind of abdominal injury. So ensure airway, breathing, circulation, immobilize the cervical spine, continue monitoring the patient, document all wounds. If you have anything protruding, cover with a sterile, moist saline dressing. Do not give oral fluids. You're going to put an NG tube in. You're going to decompress the stomach. Provide a tetanus shot, and then antibiotics prophylactically. Provide rapid transport to surgery. So evisceration and dehiscence. Lovely. Okay, environmental emergencies. This is our heat and our cold exposure. So heat exhaustion and heat stroke. It's really important in Florida to know all the differences in your heat exposures and what could occur, especially if you've got kids that are going to play sports. So heat exhaustion, they are not to the point where they're going to go into cardiac arrhythmias. Their mental status is very off. This is where they're getting those muscle cramps. They're still sweating. They could have some nausea, vomiting. Their pulse is going to be weak and rapid. Where heat stroke is an actual stroke. So they're going to have confusion, altered mental status. They're no longer sweating. Their body temperature is above 104. Their skin is hot and dry. They are probably still vomiting. Their pulse is bounding. And they're probably going to lose consciousness. So things to remember. Heat exhaustion. This is typically from dehydration or heavy sweating. So I always consider our teen athletes that do outdoor sports, especially in the summer. So like our football players. Inadequate fluid consumption, so they're out running, they're losing more fluid than they're putting back, and they're out there in the heat. How do we prevent it? Making sure that they're staying hydrated, that they're staying cool. Clinical manifestations are going to resemble flu-like symptoms. And how do we treat it? Stop the physical activity, transfer to a cool place. As soon as they start to say, oh, my muscles are hurting, I feel nauseous, this is what you're going to do. Get them into a cool place, begin those cooling measures, and then rehydrate. Soak in cool water, remove constrictive clothing. You want to do oral rehydration, so like your Gatorade, your Pedialyte. Plain water can worsen sodium deficit, so this is why you're giving your Pedialyte and your Gatorade. In the clinical setting, you're going to give normal saline. So ways that we can prevent heat exhaustion in our older adults. Remember, older adults tend to be more on the dehydration side, so they're at a higher risk for heat exhaustion. Also, they have impaired most of them, because the neurons have degenerated a little bit. Their thermoregulation is not as great. So making sure that they're avoiding things that are going to further dehydrate them, such as alcohol or caffeine, prevent overexposure to sun, take frequent breaks if they're outside, especially if it's hot, lightweight, light-colored clothing, limit activities according to sun exposure, take cool baths, help reduce that body temperature, and as sometimes, I don't see it a lot more, but back in the day when I first started nursing, especially in whole mouth, our older patients didn't have a lot of AC, so we would encourage them to go to the mall to walk around to get them out of the heat. Now, heat stroke. A failure of the body's heat regulation mechanisms are no longer working. They're completely impaired because of long exposure to long amounts of heat. So body temperature greater than 104. This is a true medical emergency, has a high mortality rate. Causes of heat stroke will be exertion or sudden onset with strenuous physical activity in hot, humid temperatures, or it could be non-exertion, so it occurs over a period of time with chronic exposure to hot, humid environment. Our risk factors, ages, so elderly, very young. Our immune system, so if they're immunocompromised, ill, or they have goodness gracious, they have debilitations, and I'll put them at a higher risk. There was a nursing home, I'm going to say like around a decade ago, that I can't even remember the name of it. It was in St. Petersburg, and they left all of their patients outside on the patio that was not covered. They all got major burns on them, and most of them died from heat stroke. So if they are in a wheelchair and they can't get up and walk around, that's a high risk situation. Manifestations, key features, a body temp greater than 104. This means when they come into the emergency room that you're monitoring that temperature rectally every 15 minutes, or you can insert a rectal probe for continuous monitoring. Their skin is hot and dry, they don't have any sweat, they have an altered mental status, rapid heart rate, rapid breathing, low blood pressure. Remember, it's stroke. Electrolyte imbalance, focus on the sodium and potassium, and they're going to be allegoric, so kidney function is going to be a problem. Heat stroke can result in death. It is a serious issue. So how do we manage it? Use your ABCs, airway, breathing, circulation. Reduce temperature as quickly as possible. Once you get it down to 102, you can stop the aggressive cooling measures. Cooling methods, you could do cooling sheets, towels, sponges with cool water, ice packs to the groin, chest, and armpits, cooling blankets. Make sure that you're doing rectal temperatures, immersion in a cool bath, eyes and nose because they're going to be allegoric, so you're going to put a catheter in them, IV lines with normal saline, monitor electrolyte and acid-base balance, monitor for cerebral edema, and get them on a telemonitor. We do not provide them with anything oral, no drinks. We're not doing that's only for your heat exhaustion. And then management of shivering. So we could give them muscle relaxants or benzos for that. So critical rescue, I put these in all of your PowerPoints for a good reason. So make sure that you're reading them. After ensuring the patient has a patent airway, effective breathing, and adequate circulation, recognize that you must use rapid cooling as the priority of care. Respond by implementing methods for rapid cooling, which include removing clothing, placing ice packs on the neck, axilla, chest, and groin, immersing the patient or wetting the patient's body with cold water, fanning rapidly to aid in evaporative cooling. Now, extreme cold, frostbite, and hypothermia. So hypothermia is an internal core temperature less than 95 degrees. Elderly, infants, persons with concurrent illness, the homeless, and trauma victims are at risk. Alcohol ingestion increases susceptibility. Hypothermia may be seen with frostbite, and we're going to monitor continuously. So our key features, we have categories of hypothermia, and it's mild, moderate, and severe. And our key features, so like mild is going to be shivering, slurred speech, mental slowdown, diuresis caused by shunting of blood to other major organs. So you could see this in our northern United States, mild hypothermia, and hopefully they can get inside and rewarm themselves pretty quickly. Now, moderate is when things start to deteriorate. So muscle weakness, increased loss of coordination, confusion, apathy, incoherence, decreased clotting, and I can't see that other one. Decreased clotting, possible stupor. Severe, they need to be in the hospital for this one. Bradycardia, severe hypotension, decreased respiratory rate, cardiac dysrhythmias, and we'll get to why they have cardiac dysrhythmias in a couple slides. But remember, hypothermia is increased potassium because of lactic acid. Decreased neurologic reflexes and coma, decreased pain, and then acid-base imbalance. So just a quick review. Stages of hypothermia. Mild, you're going to see the shivering, fatigue, and confusion. Moderate, intense shivering, worsening confusion, slurred speech. And then severe, there's no shivering, their altered mental status, hallucinations, loss of consciousness. So management of clients with hypothermia ABCs, of course, make their core body temp is going to be less than 95 degrees. So we're going to rewarm, active core rewarming with warm fluid administration, and then passive external rewarming with warm blankets and heater devices. Cardiac, make sure they get put on a telemonitor. So position the patient in supine, prevent orthostatic changes in blood pressure. The patient that is hypothermic is at risk for VFib and a pulseless VTAC. However, only defibrillate once until they get to 86 degrees or 96 degrees. Severe hypothermia, the patient is at risk for cardiac arrest. Do not externally rewarm this patient. So severe hypothermia, you are not externally rewarming this patient. That's going to cause rapid vasodilation and cardiac arrest. So why do we put our patients on continuous cardiac monitoring, especially into the mild and moderate and severe hypothermia? So cold blood returning from the extremities has high levels of lactic acid and can cause potential cardiac dysrhythmias and electrolyte disturbances. Let's break that down even further. So we are shunting our blood to those vital organs. The tissues in our extremities are no longer getting oxygen. So we use anaerobic metabolism when our oxygen levels are low. Cold temperatures reduce the blood flow, and that's going to lead to that anaerobic metabolism. When anaerobic metabolism is kicked in, lactic acid is the byproduct. So that increases. We'll have elevated lactic acid levels that contribute to muscle fatigue and decreased physical performance, and then our vessels are going to rapidly dilate. When our vessels rapidly dilate, our blood pressure drops. We're unable to clear the lactic acid, and everything gets exacerbated tenfold. So this is going to relieve elevated lactic acid, means lots of acid in your body, metabolic acidosis, and we also see increased potassium. Moving into frostbite. Trauma from freezing temperature and actual freezing of fluid in the intracellular and extracellular spaces. Manifestations, extremity or area is hard, cold, and insensitive to touch. May appear white or mottled, can be red, can be very painful when it's rewarmed. So you've lost all the oxygen to that. In this picture is the foot. You've lost all of the perfusion to that foot. So if we start to rewarm it, you're now reintroducing nutrients to those tissues, and it hurts. You're going to have some oxidative stress to that area, and tissues are going to die off. So just some pictures of your frostbite. Kaylin found some lovely picture for you guys. So you see the third spacing is occurring. So how do we treat it? Controlled but rapid rewarming. So we're going to immerse our patient into warm water. So like with this, you're not going to stick the whole body in water, just the hand. You're going to give them analgesics, over-the-counter analgesics for pain. Do not massage or handle the extremity. If the feet are involved, do not allow the client to walk. They're going to be a fall risk too. So recognize that dry heat or massage should not be used as part of the warming process for frostbite, because these actions can produce further damage to tissue. Respond by using interventions such as rapid rewarming water bath up to 102.2 Fahrenheit to preserve tissue. Now we're into our lightning strikes. So we kind of touched on this with our burns, but we're going to talk about emergency care with it now. So as we know, lightning strike is electricity that's going through the body. It enters in one area and will exit out of another area of the body. And the whole way through, it is terrorizing, causing electrical impulses throughout the whole body. It's like terrorizing the tissues. Cardiopulmonary central venous systems are profoundly affected. Asystole is the most lethal initial effect on the cardiopulmonary system. Lightning has an enormous magnitude of energy and a different current flow than a typical high voltage electric shock. The most lethal initial effect of massive electrical current discharge in the cardiopulmonary system is cardiac arrest. Because cardiac cells are autorhythmic, an effective cardiac rhythm may return spontaneously, but lightning strikes in your patient, or there is a high mortality rate with them. Treatment is immediate CPR. Victims of lightning strikes are not electrically charged. The rescuer is in no danger from physical contact to that patient. The storm can present a continued threat to everyone in the vicinity who lacks adequate shelter. Lightning can and does strike the same place more than once. So, I know we talked about this in the burn section. Can you do CPR on your patient? Absolutely. Does it need to be done? Yes, 100%. Now, is it going to be effective if you get struck by lightning, or let's say something near them got struck by lightning and there is electrical activity still happening and maybe they're in water? Who knows what's happening? That is not going to be a safe thing for you. So, yes, the patient does need CPR, but like with any CPR, you're going to look at your environment and make sure it's safe for you. So, preventing lightning strikes, you're going to check weather forecasts when planning to be outside. Lightning strike is imminent if the hair stands on end and you see a blue halo around objects or hear a high-pitched crackling noise. If you cannot move away from the area immediately, crouch on the balls of your feet and tuck your head down to minimize the target size. Do not lay on the ground or make contact with your hands to the ground. Seek shelter when you hear thunder. Leave water immediately, including indoor showers or bathtubs, and move away from any open bodies of water. Avoid metal objects such as chairs or bleachers. If inside a car with a solid hood, close the windows and stay inside. If you're in a convertible, leave the car at least 49 yards away and huddle on the ground. If inside a tent, stay away from the metal zipper in the poles. If you're caught out in the open and cannot seek shelter, attempt to move to lower ground such as a ravine or a valley. If inside a building, stay away from open doors, windows, fireplaces, or metal fixtures. Turn off electrical equipment, including computers, television, stereos, and avoid damage. Stay off landline telephones. Lightning can enter through the telephone line and produce head and neck trauma. So all of these are preventative measures when it is a thunderstorm outside. And it's actually thundering and storming right now, and I'm sitting next to my window. So hopefully nothing happens, because I want to get this lecture out to you guys. Now, this is another Galen quality picture of lightning strike through a person. You can see the electricity, the voltage, it comes out like a tree on that patient. It follows the vessels. More lightning strikes. Don't forget, with your lightning strikes, you're monitoring the entry and exit wounds, and when you're managing their skincare. Moving into altitude-related illnesses. So high altitude disease. This is exposure to low partial pressure of oxygen in high elevations. 18,000 feet or extreme altitudes are going to need supplemental oxygen. I had a student, I want to say, a little over a year ago. She's from Colorado, and she said one of her jobs as a teenager, she So she lived in the mountains in Colorado. So the job was that she would take tourists up a mountain, but they had to have oxygen tanks because of this. They had to have supplemental oxygen to give to the tourists. I found that quite interesting that they didn't need a doctor's order for any of that. Factors of high altitude disease. So factors are risk factors. It would be obesity, cardiovascular problems, dehydration, any kind of chronic illness. Central nervous system depressants will increase your risk, so that would be like alcohol or benzos. And issues with altitude sickness, so you'll see cerebral edema and pulmonary edema are the biggest ones. And then acclimatization, that is how we adapt to high altitudes. If we're doing it very slow, we adapt better. I always think about, since we don't live in a high altitude in Florida, but we do have a lot of diving, deep diving, underwater diving. The first thing that they're going to tell you is do not come up through that water rapidly. You have to go very slow so your body acclimates to that new pressure. All right, so types of high altitude diseases. You have acute mountain sickness, high altitude cerebral edema, and high altitude pulmonary edema. So your acute mountain sickness, you're going to see headache, anorexia, nausea, vomiting, chills, irritability, and apathetic. High altitude cerebral edema, you're going to have dyspnea at rest and inability to perform ADLs. When you have pulmonary edema, this is the most common cause of death associated with high altitudes, and manifestations include poor exercise intolerance, coughing, persistent cough, cyanosis, especially circumoral, so blueness around the lips, tachycardia, tachypnea, and crackles that are pink and frothy. So how do we treat it? Acute mountain sickness, you're going to do Diamox. That's a sulfa drug, so make sure that you're not giving this to a patient that has a sulfa allergy. This is your acetylizumide. This is a sulfa drug, no sulfa allergies. This induces diuresis, so you're getting rid of the excess fluid. You want to take it 24 hours prior to going up the mountain and continue for that first 2 days of the trip. For high altitude cerebral edema, you're going to give dexamethasone to decrease inflammation. For high altitude pulmonary edema, you're going to give things like tadalafil and sildenafil, your phosphodiesterase inhibitors, to prevent pulmonary vasodilation. Remember, edema is vasodilation. Or you can give nifedipine, which is your calcium channel blocker, and that's going to decrease pulmonary vascular resistance. Make sure altogether with any of these, you're avoiding alcohol, any kind of CNS depressant. Avoid alcohol and sleeping pills. Recognize altered mental status symptoms. So if you're getting more confused, you're going to implement your descent from that mountain. It's going to be a slow ascent to allow your body to acclimate, but you're going to start to descend immediately, but it's going to be slow. Avoid overexertion and overexposure to cold because our blood cells need that oxygen, and rest at present altitude before ascending further. And now our water-related drownings. So drowning is leading cause of death in the United States. It is really high in Florida, the states that have beaches, lots of pools. Suffers from primary respiratory impairment from submersion or immersion in water or other liquid substances is what drowning is. So health teaching, constantly observe people who can't swim. Do not swim alone. Avoid alcohol when swimming or boating. In safety equipment, make sure there's a life jacket, a flotation device, and a rope on your boat at all times. You can actually get a really hefty ticket if you don't have those things on your boat and you get pulled over. So drowning assessment. Water is aspirated into the lungs, and the most important is duration and severity of hypoxia. How long were they not breathing? Because that's going to indicate anoxic brain injuries. Very cold water seems to have a protective effect on our patients. So hypothermia might offer some protection to hypoxia. It kind of preserves it. And I've always found that very interesting because when our babies are born really premature, they will make them hypothermic for a good 24 hours to kind of reduce the inflammation and the oxidative stress. How do we get water out of the drowning victim's lungs? Well, we're not going to try and swipe it out. What we're going to do, especially if we know that the airway is obstructed, we're going to do chest and abdominal thrusts. That is very important. You are to do chest and abdominal thrusts, depending on their age. Hospital care, airway and cardiopulmonary support, so oxygen, they could be intubated, CPR, they could be defibrillated, whatever is necessary for that patient. They're going to be NG tubed to decompress, increase ventilation, and they are high risk for acute respiratory distress syndrome. Now, our disasters and mass casualties with our bioterrorism. So disasters that produce mass casualties: tornadoes, hurricanes, fires, explosions, multiple vehicle accidents, plane, trains, boats, and bus accidents, and then our terrorist attack. This is everyone's worst nightmare. So a disaster, event in which an illness or injury exceeds the resources capable of the healthcare facility or community due to destruction and devastation. So if you're in, let's just take our local hospitals. If you are in South Shore and Sun City, they are not built for mass casualties. So if we look in the area, the hospitals that are built for mass casualties are trauma centers, are Bayfront, Tampa General, St. Joe's, Maine to an extent. Multi-casualty can be managed by a hospital using local resources and mass casualty. So local medical capabilities get overwhelmed very easily in that and may require collaboration of multiple agencies surrounding that area to handle the crisis. So if you've got, let's say, 100 patient mass casualty and they're all in the Sun City area, that little South Shore hospital cannot handle that. So what are they going to do? They're going to start diverting patients to a more trauma-focused hospital that can handle the situation. Emergency operations plan. So healthcare facilities are required by the Joint Commission to create a plan for emergency preparedness and practice this plan twice a year. I know that Baker calls it Code Green, and you'll see them participate in like a simulation, and they're constantly going in and out of different areas of the hospital. Essential components of the plan: so an activation response, internal external communication plan, a plan for coordinated client care, security, identify external resources, and a plan for people management and traffic flow. It cannot be disorganized mess. Is it going to be anyway? Absolutely. But you need to have these plans in place so that there is some kind of flow, and that people are being saved more than they're dying off. So action alert. In a mass casualty or large-scale disaster situation, implement a military form of triage with an overall desired outcome of doing the greatest good for the greatest number of people. If resources are severely limited, this means that patients who are critically ill or injured might otherwise receive attempted resuscitation during usual operations may be triaged into an expectant or black tagged category and allowed to die or not be treated until others have received the care. So precautions for biologic terrorism. The closest thing that I can think of that occurred in my lifetime was anthrax. There was a point in time that we were even afraid to open our mail. It is where biologic agents may be delivered or spread in a number of ways. Spread of agent may occur in areas thousands of miles apart, and healthcare providers need to be aware of potential signs of biologic exposure. Signs and symptoms are similar to those that have a common disease process. So, our precautions for our biologic terrorism. Isolation practices depend upon the infected agent, and it takes a couple people getting severely injured to recognize that it's a problem. We're always going to use standard precautions. Some agents require transmission-based precautions. So you see them in this picture. That is what your transmission-based precautions are. Terminal disinfection and disposal of waste depends on the infective agent. So, some precautions are airborne or droplet under contact. Precautions are the most important aspect of disaster involving bioterrorism. So, remember COVID, if you guys ever worked in the hospital during COVID, did we have enough of these precautions in place? Absolutely not. They were telling us to they gave us all one N95 and telling us to put it in a brown bag for safekeeping. Is that best practice? Absolutely not. But we did not have the resources. We didn't even have the resources to make enough alcohol-based hand sanitizer. If you guys remember, the alcohol distilleries were shutting down to make hand sanitizer. But just know that you are priority, and you have a choice whether you're going to be doing that or not. The great thing is places like TGH that have wonderful funding from things like USF, they didn't have any problems with PPE. So just a little FYI. Airborne, droplet, and contact precautions. So airborne, this is where you're getting your N95 mask. You're going to wear a gown, gloves, and this is typically seen with your TB and your measles. They should be in a negative pressure room. Now, most of the COVID patients back in the day should probably have been in a negative pressure room as well, and we should have been using our airborne precautions. But as we all know, there weren't enough rooms for the amount of care that was needed. Droplet precautions. This is for like your flu. This is just your surgical mask. You should gown up and should put gloves on. And then your contact is just your gown and your gloves. This is more for like your MRSA. And then standard is just gloves. So triaging in a disaster. The key principle of disaster care is doing the greatest good for the greatest number of clients. While the objective of conventional medical care is to do the greatest good for the individual client. In disaster situations with large numbers of casualties, triage decisions are based on the likelihood of survival and the consumption of resources. So, thinking about our vulnerable populations, who do we take first? Who do we pick to live and not live, right? So, vulnerable populations, young infants and children, older adults, people with disabilities, those that have psychological concerns, and those who require devices such as a mechanical ventilator or home oxygen. Always keep them in mind. Disaster triage processes should incorporate strategies to accommodate these populations. But if you've got 200 people coming into the ER in a mass casualty, who are you going to take first? So emergent is immediate threat to life. Urgent means injuries that require immediate treatment. Non-urgent, injuries that do not require immediate treatment, and the others do not apply. So under a mass casualty, emergent gets a red tag, and it is immediate threat to life. Urgent gets a yellow tag, major injuries, requires treatment. Non-urgent or class 3 is green. They do not require immediate treatment. And then your black tag, expectant, we're going to let those patients unfortunately pass away. So some examples of those: emergent or your red tag, airway obstruction or shock. Your yellow tag or urgent, open fractures. They still have pulses, but they have large wounds. They need treatment within 20 minutes or 2 hours. Your non-urgent, your green tag, they are going to be okay. They can wait a little bit. Walking, they could have a wound, they could have closed fractures, maybe a contusion. Expectant is your black tag, those that we are not going to focus on. So that would be your head trauma, full thickness body burns, high cervical spinal cord, those that have severe injuries that would require a massive amount of people to care for them. So managing the short and long-term psychological effects of a disaster. Critical incident stress management, the CISM team. Most hospitals have this. I hope that all hospitals have it, but I can't speak for all. This is programs that include education, field support, diffusing, debriefing, and follow-up components for disaster victims. It is a team of, it's an interdisciplinary team that shows up to help the staff at the hospital after the occurrence to keep them from developing PTSD, really. Persons with ongoing stress reaction should be referred to mental health specialists. The CISM team also helps with this referral. Managing short plus long-term psychological effects of a disaster. Provide active listening and emotional support. Provide information as appropriate. Refer to therapists and other resources. Discourage exposure to media regarding the event. And encourage return to normal activities. I will never forget one of my patients saying, she was a nurse, and she said they wanted me to go to therapy. I went to therapy, and they're like, let's dive deep into that COVID. You worked during COVID, and she's like, nope, we're not digging into that. She said, it's better just to ignore it and keep moving. And unfortunately, that's a thought process for a lot of healthcare workers, is to just forge through and keep moving through it. And sometimes that does work, but in other times it doesn't. So you have to know you and how you are handling things and coping. Ultimately, though, getting back out there and doing your normal activities is really important to keep your mind occupied and busy. And that is all for our last unit. I will see you in class. Have a good day.